For a neonate to survive outside the womb, 3 immediate physiological changes must occur the moment they are born. First, the lungs must cease producing fluid and clear the existing liquid. Second, the lungs must aerate to establish functional residual capacity, the baseline volume of air kept in the alveoli. Third, the circulatory system must completely shift from its fetal pathways to an adult configuration. When these transitions are successful, the neonate requires standard observation. Hospital neonatal units are structured into distinct tiers based on the level of care required. Level 1 units handle normal, full-term infants without complications. Level 2 units, or special care nurseries, manage moderately premature neonates or those with mild issues like physiologic jaundice or suspected infections. Level 3 units are neonatal intensive care units, or the NICU. Admission here follows strict criteria. Any neonate born before 34 weeks of gestation, weighing under 1,800 grams, or requiring active mechanical ventilation and intensive physiological support is immediately transferred to Level 3. Triage at these extreme lower limits of gestational age is defined by precise thresholds. The World Health Organization sets the general viability threshold at 24 weeks gestation and 500 grams of body weight. However, within specialized, highly equipped Level 3 centers, survival is now documented in neonates as young as 22 weeks and weighing just 350 grams. Immediate neonatal survival depends entirely on one of 2 paths: a flawless autonomous physiological transition by the infant, or immediate protocol-driven triage to the appropriate level of care based on their gestational age and clinical presentation. This table outlines the APGAR score, evaluated at the 1st and 5th minutes of life to quantify physiological stability. It measures 5 parameters, grading each from 0 to 2: skin color, heart rate, reflex irritability, muscle tone, and respiratory effort. Based on these parameters, neonates are sorted into immediate triage categories. Triage Group 1 includes neonates with normal breathing and a heart rate over 100 beats per minute. They require no intervention. Group 2 includes infants who are apneic but maintain a heart rate over 100. They typically recover their breathing with basic tactile stimulation. The interventions escalate for the remaining groups. Triage Group 3 neonates exhibit cyanosis despite a heart rate over 100 and require supplemental oxygen therapy. Triage Group 4 represents an immediate emergency. These neonates are pale or cyanotic, hypotonic, and apneic. They require immediate, active resuscitation. The APGAR score dictates the algorithmic progression directly into active neonatal resuscitation protocols. A low score triggers an immediate mechanical and pharmacological response. That response follows the strict ABCD clinical algorithm. Step A is establishing the airway. Step B is breathing. If the neonate is apneic, clinicians initiate positive pressure ventilation at a specific rate of 30 to 40 breaths per minute. Step C addresses circulation. If despite effective ventilation, the neonate's heart rate drops below 60 beats per minute, providers must immediately initiate chest compressions to maintain systemic perfusion. Step D introduces drugs. If the heart rate remains stubbornly below 60 beats per minute after at least 30 seconds of coordinated ventilation and chest compressions, pharmacological agents like epinephrine are administered. Strict adherence to this ABCD protocol provides the only definitive method to arrest perinatal hypoxia. Executing these steps exactly in order prevents the lack of oxygen from causing irreversible neurological or organ damage. This radiograph shows the classic presentation of respiratory distress syndrome, historically known as hyaline membrane disease. The condition presents with characteristic ground glass opacities on an X-ray. This pathology is caused exclusively by a deficiency in pulmonary surfactant, the specialized lipid-protein mixture required to reduce surface tension and keep the alveoli from collapsing. Its incidence has a direct inverse relationship with gestational age. RDS occurs in 80% of premature neonates born before 28 weeks, dropping sharply to just 2% for those born past 37 weeks. Predisposing factors, such as maternal diabetes, can further increase these risks. Because the primary cause is a lack of maturity in the lungs, prophylactic strategies focus on accelerating fetal development. The standard protocol involves administering corticosteroids to the mother at least 48 hours prior to an expected premature delivery to stimulate the synthesis of fetal surfactant. When prevention fails, acute clinical management is required. This involves oxygen therapy and mechanical ventilation, which is necessary in 2/3 of severe cases. Crucially, it also includes the direct endotracheal administration of exogenous surfactant to artificially stabilize the lungs. The primary objective of managing RDS is to stabilize alveolar surface tension as quickly as possible. Prolonged mechanical ventilation on fragile, collapsed lungs directly leads to bronchopulmonary dysplasia, a severe chronic lung disease. Not all respiratory distress indicates surfactant deficiency. Transient tachypnea of the newborn is a temporary condition caused by the delayed clearance of fetal lung fluid. It is highly correlated with scheduled cesarean sections, where the physical compression of a vaginal birth is absent, but it typically resolves entirely within 12 to 72 hours. In contrast, this X-ray reveals the typical presentation of Meconium Aspiration Syndrome, or MAS. The pathophysiology of MAS operates on 3 destructive levels. First, the thick meconium creates a mechanical airway obstruction, leading to the hyperinflation visible here. Meconium-stained amniotic fluid occurs in 13% of deliveries, mostly in post-term pregnancies facing hypoxia. MAS develops in 6.4% of those cases, when the fetus inhales the thick meconium deep into the respiratory tract. Second, the meconium triggers a severe chemical pneumonitis. Third, the resulting hypoxia leads to persistent pulmonary hypertension. Because of the physical nature of the obstruction, the mandatory acute intervention for an apneic neonate born through meconium is immediate endotracheal intubation. Clinicians must mechanically suction the meconium out of the trachea before initiating any positive pressure ventilation to avoid pushing the debris further into the lungs. These 2 primary respiratory emergencies represent opposite ends of the gestational spectrum. RDS is a disease of prematurity and physiological deficiency. AMS is a disease of post-term stress, hypoxia, and acute physical obstruction. Beyond the lungs, the greatest risk to premature infants lies in the brain. Intraventricular hemorrhage, or IVH, is a primary risk for fetuses born before 32 weeks. It originates in the germinal matrix, a fragile capillary network near the brain's ventricles. This ultrasound captures the resulting hemorrhage. They are graded by severity. In grade 1, bleeding is restricted to the germinal matrix. In grade 2, blood extends into the lateral ventricles without dilation. In grade 3, ventricular dilation causes hydrocephalus. Grade 4 is catastrophic, breaking through ventricular walls into the cerebral parenchyma, destroying brain tissue. Severe IVH leaves a wake of devastating downstream complications. Survivors face hydrocephalus with surgical shunts, severe cerebral palsy, severe cortical blindness, and permanent deafness. The premature brain is vulnerable because the structural immaturity of the germinal matrix simply cannot withstand the massive fluctuations in arterial pressure that occur during perinatal hypoxia and acidosis. When blood pressure spikes, the fragile vessels rupture. While IVH is driven by hemorrhage, periventricular leukomalacia, or PVL, is driven by ischemia. PVL is a severe lack of blood flow resulting in tissue necrosis, located in the subcortical white matter, strictly accompanied by cerebral edema. Unlike intraventricular hemorrhage, which is intrinsically linked to extreme prematurity, periventricular leukomalacia is a critical neurological lesion that frequently impacts full-term neonates. It is the direct, devastating neurological consequence of severe hypoxic events suffered during the labor and delivery process. Mitigating perinatal mortality and preventing severe neurological morbidity requires a seamless, unbroken continuum of care. Survival depends on aggressive, protocol-driven resuscitation in the delivery room to prevent hypoxia, flowing directly into the highly precise diagnostic and mechanical support provided within the Level 3 intensive care unit.